First, what I want to highlight before we actually get into the anatomical findings of where we're going to go, I want to make sure we understand something here. We need to figure out which patients are IO candidates. And the answer is defined in the protocol. It's definitive therapy. This is for definitive therapy that you're going to be providing it. So typically what we do when we're doing definitive therapy for a patient, our typical first go-to is going to be IV access, right? And when that doesn't work, we typically do what?
The other arm?
The other arm. There we go. That's the reasonable thing. The idea of a person who needs something from you, though, can shift and can change. The way we've classically taught this is you try for peripheral IV access, and then you consider second peripheral IV access, and then you consider EJ access. You might see this a lot. My thing for you guys and what I want to take moving forward is updating how we go about things, updating our process. EJs are great, they are fine, but when you're dealing with people who have poor vasculature and are already compromised because they need definitive therapy, right? You need to identify that you might not be able to get this. If you can't see this, you don't see access, you've already failed once, why isn't that patient getting an IO? But not just any IO, the humeral IO. The bulk of what we're going to talk about today is glorifying and utilizing the humeral IO, and we'll also do the tibial tuberosity too. I do want to state though, in your protocols, what does it say regarding tibial tuberosity versus humeral IOs?
I'd like to try a tibial first.
Tibial is
That's what it
the
says.
preferred method.
But don't worry, it's going to be changing sooner than later, and there's a lot of entities in play who are going to play into this. This isn't just the yammerings of me being crazy. This is stuff that's coming down the pipes. The humeral IO has been proven time and time again to be superior. So that is going to be what we'll focus on. But before we get to that, we need to understand the equipment. We have first catheters. We have 3 catheter sizes. We have a 15 millimeter catheter, not featured here today. That'll be a second semester responsibility. There's an upper limit to what that can be used on. A very low, a very small amount of patients will utilize that catheter. This will be used in a lot of cases. It will be used in a lot of cases. However, it's typically used mainly for tibials because humerals require the larger needle. Just the same, these find themselves used and should find themselves used a lot of times in the pediatric realm. The other size that we have, and I'll just show you the needle and catheter itself, is going to be the yellow. This is the 45 millimeter catheter. Now, breaking down what you have here as far as the catheters are concerned, we have black lines that are along the catheter. The pink ones have 1 black line, the blue ones have 2, and these ones have 4. The goal of these lines as you will perform your skill is to assure you're using the right size tool for the job. These catheters are intended, once placed on the IO driver or being used in the Jim Sheedy method, whatever the case is, the first thing you do is you go in at the appropriate angle, in this case 90 degrees on the tibia, and as long as you see at least 1 black line, you know your tool is big enough for the job. Now, if you can't see a black line, that's when you know you need to go 1 size higher. If you can't see a black line on this one, God help you and your patient. But it applies mainly to this one. We often find ourselves jumping and gravitating towards this device, but it can easily be sized out of. So statistically speaking, you are more likely to be successful with any IO access utilizing this one over this one. But again, you can use caution, and there is a couple of size stipulations. I'll talk about those in a second. Now, actually I should talk about this before I move on to the other parts of this thing. What we have here is 2 components. We have the catheter, which is this here, and we have the stylet, which is what I'm pulling out right now. It's been used a lot today, so it's a little sticky, but this catheter, this stylet is basically the needle that's inside. It's the same thing that you actually call an IV catheter. An IV catheter actually has a stylet that goes into it. So just want to make sure you guys are familiar with the terminology, but this thing unscrews and should be firmly seated when you're performing the IO skill. Now, the catheter itself actually has a cool feature. Besides the lines, you'll notice that it's kind of forked like this. The fork here is so when you get your access, even if you find yourself somewhat embedded in the other side of the bone, which you can kind of see on here where it's scraped along the side, this means that even if you're scraping along the other side because you went in so deeply, there's still a good likelihood this thing is totally viable and totally usable. It's very good. That's why it's forked. It's similar to how a suction catheter has multiple holes on the tip. Now, the other things that are in this packaging incorporate a fidget spinner or extension tubing. This thing is fantastic. It doesn't tangle, and it can also hire slightly higher pressures, though it's not typically regulated for pressure infusers. Pressure infusers are things that are utilized in cath labs, STEMI centers, trauma centers, people who have the acute abdomen. Those patients get CT contrast, IV contrast. Those patients require large veins with large catheters in order to support it, and so they don't burst. If they're not, the pressure's too high, extension tubing can burst. This is a little thicker and it's more resilient to it. It needs to be, because a lot of times, especially if it's a tibial tuberosity IO, it's going to require extra pressure in order to overcome those pressure gradients. So that being said, while it's not quite at the level of a power injecting thing, it will typically still get the job done. But I will warn you, if you're using the extension tubing that's provided in most ambulances and is available there, that stuff is very poorly made. It's very thin, and those have been known to explode in those situations. Try not to use those with your IOs. Use these with your IOs. It comes in the packaging. Next is going to be your saline flush, which is typically packaged like this. It should be kept in the same package and should be in a package. It's 10 cc's. This is what you're going to attach to your extension tubing and have it pre-designated. It should look like this. Now, I will say this. You will always, no matter what stage your patient's in, conscious or unconscious, you will never put lidocaine in this system. This system will always be preordained and set up just like this. I want to make sure you understand that. More on that in a little bit. Next is this. Right here, we have this little ID band. This ID band is utilized for marking the extremity that has the IO. You mark it with a date and time, similar with the tourniquet. Now, because for time-sensitive purposes, I'll just cut to it and tell you guys. Basically, bones heal within 2 days. 48 hours from when the IO is pulled out or when the IO is failed is when the bone can be accessed once again. So that's something important to note. And the other important thing to note is if your IO is successful, it will last for 24 hours. 24 hours it will last, and then 48 hours after that before another one can be put in. So it's a 72-hour period with the good IO, 48-hour period with the bad IO. You will always remove the bad IO. This thing, I can't culturally tell you guys to put this on right after you do the IO, though it would be nice, and I hope that will be somewhere we take this in the future. But I will say, when you hand this patient over at turnover, that you come over and you place this on the patient's extremities. If not for the good IO, it's for the time you may have missed an IO or something didn't work out. This is most important for the extremity that doesn't have anything in it anymore. And I want to encourage that. If the IO is not good, it has to be pulled, because you guys have seen the cacophony of noises and activities that occur in hospitals when they're not running a code. The code is running them. And you can see how they'll potentially utilize a poor IO. So you will always remove the IO, and in its place, you will make sure this is there to let them know that it can't do one on it anymore.
Quick question.
Yes.
If you get a bad IO, do you have to swap legs, or can you go back in the same leg?
No, and that gets into the contras, and I'll talk about those contras in just a moment. Let me just hit this last part of the equipment here. Oh, and it's going to be this one here. So this is the sharp shuttle that comes in it. You will sharp it temporarily in here, and when I say sharp it, I mean the stylet. The stylet gets sharp. Hopefully this thing will find itself where it needs to be, but if that one's bad too, then you'll have to probably directly put that in the sharps container. But once it's done, and when you're practicing here today, what we're doing is going to be physically working on the skill, finding the landmark, finding how we're going to do it, getting it in the spot it needs to be in, and then once all said and done, you will remove it just as if you were to move a bad IO, and then you will sharp it. That's what you're going to do today. You will always sharp. Anytime you do an IO, you are always going to sharp your IO needle. That way you'll never negative train. Right now, we're planting the seed of how you properly do it, how you properly find your spot, and then once all is said and done, how you properly sharpen your needle, and then once the skill is done, that's when you can remove it. And when it comes to removing a bad IO or removing from that sharps container, and a question came up before, why would I remove it from the sharps container? No, you wouldn't. It just happens to work out that way, that it works for both skills. And I stumbled upon this one day when I was lecturing, doing my little fidget spinner thing like this, and I made it come off. That's how you guys will still use this. So you don't actually get rid of this by keeping it like this. You can actually just unscrew it. Now I recommend you don't have to do what I just did and keep spinning it. You can just do consistent motions in one direction while pulling tension on it, and it will pull it out. So that's my recommendation. Now let's talk about reasons we would pick access. What would keep us? If I were to tell you guys that the humeral IO is the place to go, what would keep you from going into the humerus? What are contras?
Amputation.
If there's an amputation and we can't access the site at all, absolutely, because then that means that bone's not a capable
Humeral fracture.
fractures in the same extremity. That means the patient you're actively dealing with has a fracture in the extremity, but that also segues into another contraindication. What might that be?
Tibial fracture.
Well, tibial fracture for the other one, but in general, if we're talking about integrity of the bone, I'll cut right to it. Surgical, pre-existing surgeries that the patient might have, or surgical history that is known of in that particular extremity might deter you from using that. I say might because not every surgical process, but the fact is if surgical processes have occurred, then we're gonna just opt to go to one of the other 3 extremities that are available to us to get that done. That might sometimes mean you can't do either of these locations and you have to go below. There's a reason to do a tibial IO right there on the spot. So previous surgeries, we have fractures or known fractures at that potential location, and then what you had asked me before, if you've attempted, yep, whether you got it or not, whether you even know you pierced the space, it doesn't matter. It's offline. You cannot use it for 2 days. So that is a contraindication to try twice in the same extremity. So the other one is going to be infections, known infections of the legs. So think about those skilled nursing facility patients or patients who might not have that type of history backing them up or that context, and you assess them and you find that there's obviously some type of infection or maybe phlebitis in those drug user patients. Those are all patients that this is contraindicated in that particular extremity. We need to go to another one. Remember, sepsis and sepsis is the idea of bacteria and toxins getting into the bloodstream. If you break through the compartment that potentially has infection, you are breaking infection through to the rest of the body, and thus septicemia follows. Yes?
When it says vascular disruption, what does that mean? How would you know?
Vascular disruption falls in with the fracture concept. Basically, what you're dealing with this space here is if you have a break in the integrity of this bone, that's going to be your vascular disruption. If you're dealing with PMS that's broken or fracture, then we cannot use it. So any of those things explain effectively that vascular disruption in that particular extremity. And you'll notice it in patients who do have it. I'll use the AAA patient, for example. That patient will have a leg that looks gray and the rest of their body will be a different color. That's a good example on a medical level of what vascular disruption might look like.
Does that fall under like osteoporosis and bone cancer?
Those patients, while you could potentially find yourself dealing with very thin bone compartments and very probably Jim Sheedy-ish type bones that you might have to deal with, they aren't necessarily contraindicated. You can still do the IOs in those patients. Now, with that being said, let's talk about the process of doing this. What you're trying to do in either case is you're trying to access the heads of a large bone in the body. In the heads of the bones is where you're typically producing red blood cells. In the middle of the bone, you typically have like fat and things that are inside. So that's why when you get IO access, you can sometimes see red or you can sometimes see yellow marrow. Red marrow is going to be typically made here. Thus, if you're getting red marrow, you're probably right where you need to be. If you see yellow marrow, that doesn't mean everything is bunk. That just means that the flow might not be as good as if you were up here in the more the proximal areas. So keep that in mind. Yellow is just a reflection of probably being lower than you should have gone, but you're still good and the skill is still functioning and the party can still go on. But that's the difference between red and yellow marrow when you're doing the skill. You're more likely to see yellow marrow in the tibial IO because it's an unforgiving area where it doesn't take very much to miss it or go too low. Unlike the humeral where the space is a lot more expansive. So Contraindications checked off that. Now let's talk about the physical act of palpating this. When you're trying to figure out where, when you're gonna decide that your patient needs an IO, what you're typically gonna do is this. I've tried my access, I'm gonna do IO. What Teleflex has told us to do is you need to at first try and do the right humerus. The reason they want you to do the right humerus first as the primary spot to do humeral IOs is because the right humerus has little pores. In fact, all these heads do. Where they make red blood cells, there's a bunch of little pores here where the capillary beds meet, and it makes it very easy for you accessing and infusing fluid going directly into your blood supply. Well, the subclavian vein is right here. So it dumps immediately into that and within seconds gets to the heart. Your greater vessels, everything right here, dumps right into here. That's why this is advantageous. This side, it's still humeral, it still functions, it's still gonna be quick, not as quick. I won't nitpick you guys in Simland regardless of one or the other. I'm just saying that if we have to choose, this is gonna be by process. The first place we go, the second place we go, tibials will be the third place. Who cares what leg you want at that point? They're more distal than what we're dealing with now. Now, when it comes to finding your locations, what you guys will do with each other is this. Number one, you need to make sure that you position the arm accordingly. That means either abducting the thumb, just like so, or bending the arm, just like so. Those are your two selections. I recommend this because a lot of times these patients will probably be in cardiac arrest, thus it's easier to manage this than it is to manage a patient like this because Lucas devices will bring the arms up like so. This will be how we manage these patients. Now, once that's done, gone are the days of doing what that protocol tells us to do. That protocol book is old literature. The stuff that I'm gonna tell you now is based off of the people who made the device. Teleflex owns Aero Easy IO. They recommended basically this. You take your palm, everybody can take their palm, and you see a little divot right here. That divot is almost gonna be like the bottom of a Lego. It was made for the humeral head. What you're gonna do is you're gonna go anteriorly and you are going to circle around and find exactly where your palm fits. And that's where the humeral head is. You almost can't miss that. Now, here's the deal, and this is another contraindication. If you can't feel it, guess what? You're not gonna do it. So there it is. You feel it or you don't. In most cases, you'll feel it. You should feel it on everybody, and it will be us getting used to doing it on each other, just like so. But if you can't feel it, then that's the contraindication. That means you anatomically can't probably get it right, and that also has a strong likelihood that this thing is probably not going to be big enough for what it needs to do. So once it's rotated, you feel anteriorly. Once that's done, your skill will then go about pointing the driver 45 degrees from the head, 45 degrees from the head. It's 45 degrees above the waist. You're pointing towards the opposite hip. The rule of 45s, that's what governs this. Everything that gets accessed up here, IO-wise, is at a 45 degree angle. 45 degrees from the head, 45 degrees from the bed. This is gonna be my angle for IO access. Right here, just like that. So I'll demonstrate that on here, but that's what you guys are first gonna demonstrate on each other. I don't know if you wanna pause the video for that part.